Hello everyone and welcome to our Michigan Medicine Live event. I'm Ed Bottomley with the Michigan Medicine Department of Communication, and today we'll be discussing back and neck conditions and the latest in surgical options. So let's meet our experts first off, Dr. Rakesh Patel and Dr. Ilyas Aleem, surgeons from the Department of Orthopaedic Surgery here at Michigan Medicine. So can we just take a second, could you introduce yourselves, give us a little bit about yourselves?
Yeah, absolutely. So my name is Rakesh Patel, born and raised in New York City, went to medical school out there and did my training. My first foray into the Midwest was in my fellowship where I went to Wisconsin, and I fell in love with the college town feel of the Midwest and found my way back to Michigan, where I've been here now for roughly 10 years in the Department of Orthopedic Surgery.
Fantastic. Dr. Aleem?
Yeah, so I'm actually just north of the border here. I was born and raised in Canada. Did my training, most of my training at the University of Toronto, and then was fortunate to do a fellowship at the Mayo Clinic, and was sort of looking for jobs both in Canada and the U.S. and then ended up here at the University of Michigan in Ann Arbor. So fortunate, my wife's from Chicago, so Chicago, Toronto, this ends up kind of just halfway for us, so works out well.
Fantastic, and I'm glad to have both of you here today. Before we get stuck into the questions, just a reminder for everybody viewing, you can submit your questions at any time, even now, for our panelists to answer during the Q&A portion of today's chat. And you can submit questions by commenting on this video, but please note that your name or your profile name will be visible to others participating. If you prefer a more anonymous option, you can also send us a private message via Facebook. Now, if you can't stay for the whole chat, or if you want to share this recording with a friend, a video of the chat in its entirety will be up on our Facebook page later today and posted to the Michigan Medicine YouTube channel soon after that. So let's move on to our questions. So we're here to talk about surgery of the back and neck. Before we do that, let's start with some more general questions for you guys about the conditions that affect a person's spine. So first question up, what are some of the more common back and neck problems you guys see in clinic?
Yeah, so most of the stuff that we treat is degenerative in nature, secondary to arthritis. So we take care of a lot of patients with herniated discs that are causing sciatica, with really bad back pain and leg pain. Similarly, in the neck, you can have a herniated disc causing really bad arm pain. We take care of spinal stenosis, which is extremely common in the older demographic. It makes it difficult for people to walk for any prolonged distances and really affects their quality of life in a negative fashion. And we also do deformity surgery as well. So for patients with scoliosis, not just kids, but adults develop scoliosis as they get older, we take care of that as well. Being at a tertiary referral center, we're also privileged to take care of a lot of patients that have had surgeries elsewhere, which really haven't gone expected to plan, and they come over here and we have the opportunity to take care of them. Being affiliated with University of Michigan, we have an opportunity to take care of athletes as well, collegiate athletes and also some professional athletes. So kind of a varied mix of conditions. But anyone with anything either causing axial neck and back pain or any type of neurological disorders because of spinal cord or nerve compression.
Fantastic. Anything to add, Dr.
I think along with all that, just given the nature of the practice here, we also have a fair amount of practice that deals with trauma patients. So compression fractures, osteoporotic compression fractures, and even higher energy traumatic mechanisms to the spine resulting in fractures or instability are also commonly seen.
Okay, now moving on with still in our topic of more general questions, how do you determine if back or neck pain is caused by muscle, nerve, or joint problems?
You want to take that?
Yeah, I think that's an excellent question. I mean, back pain is a very common thing. About 80% of people experience some episode of back pain in their life, and the spine itself is it's a very complex structure, complex organ, you can say. It involves bones, involves ligaments, involves discs, involves cartilage, involves muscles, numerous joints, and of course nerves as well. And then just by location, when you think about the neck, you have the shoulders there as well, and then lower down you have the pelvis, you have the hips. So an important component of deciding where the problem is coming from in the spine is a careful history of the patient's complaint, as well as a detailed physical examination. I think it's very important. Often people come in with complaints of certain pain or certain location of pain, and they think it's one thing because the MRI shows something. But by doing a detailed history and physical examination of the patient, we often find that they're coming in with, let's say, neck complaints, and it's actually a shoulder, or back complaints, and it may be their SI joint or their hip, it starts with that, and then obviously assessing the imaging, starting with X-rays and then advanced imaging, is a very important part of determining where exactly the pain is coming from, so we know what to treat.
Yeah, I think the hardest part of our jobs as spine surgeons is not actually the surgical aspect of it, but it's making an accurate diagnosis. Because you could be the slickest surgeon in the world, but if your surgical indication is not appropriate, the patient's not going to do well. And you keep hearing stories of patients who've had family members not do well with spine surgery. And I could tell you the vast majority of those patients never had a chance to do well because they shouldn't have had surgery in the first place. So determining who has pathology that you can actually help surgically is by far the most challenging part, but also the most important part of what we do. And like Ilyas said, a lot of this involves not just looking at MRIs. MRIs in people change as you get older. So just like you lose hair or you get some gray hair, as you get older, your MRI will show some changes, but that doesn't necessarily mean that's a source of your pain. This is why some patients ask us to review MRIs and call them on the phone and then tell them what to do. That's an impossibility because those imaging changes need to be correlated, like Ilyas pointed out, to physical exam and a really detailed history. So this is why that first initial new patient interaction is so critical.
Thank you for that. I think that's a really important point there. The next general question we have, what is the difference between a herniated disc and a degenerated disc?
Well, I think it's all, and I think it's all on the same spectrum. And, like Dr. Patel mentioned, MRI findings, whether they be in the discs or in the joints, are all very, very common. They're normal. So normal wear and tear as people age, they get MRI findings of things like degenerative discs and whatnot. From that to a disc bulge, to a herniated disc, to an extruded disc and whatnot. I mean, they're all on a similar spectrum. What's more important, again, there always tends to be a focus in our patients on what the MRI shows. Mm-hmm. And what's really important to us is what the patient themselves show or what they're telling us, what their symptoms are, and what their physical examination shows and whatnot. So I would say that, with regards to differences between the two, I mean, they're on the same spectrum. A disc starts off by degenerating and showing degenerative changes and collapse. It could herniate out and generally, or it may herniate out and compress the nerve. And if it starts doing that and causing, for example, leg pain, so not necessarily back pain, but the patients start having leg pain, that does not improve with non-operative treatment, then those are the patients that we can potentially help surgically. But again, we don't just jump to surgery based on MRI findings.
So I'm lucky enough to have a wonderful 8-year-old daughter who's really interested in all things medicine. And she asked me a million questions. And one of them is about discs. So it's funny that when we say discs, we're so used to operating on them and seeing them and touching them that you sometimes forget that people who don't have that clinical experience that we have don't have any concept of what a disc looks like. So my analogy to her as to what a disc is, it's like a jelly donut, and it's a shock absorber in between the vertebrae. As you get older, some of the jelly goes away and it becomes a pancake. So you feel more load when you jump or when you do any impact activities. Sometimes when you're young and you still have jelly on the inside and you get a hole on the outside, that jelly leaks out. When the jelly leaks out, that's called a herniated disc. And when that jelly pushes on a nerve, it can cause shooting pain on the leg and sciatica. And that's something that we can help out surgically fairly often. So sometimes people get herniated discs. Everyone gets degenerated discs. I'm 44 and my MRI shows plenty of degenerated discs at this point in time. He's younger, so it looks, looks good.
So the next one, this is a follow-on. We've already touched on a few of the points here with degenerated discs. Can a degenerated disc be stopped or slowed down?
Yeah, so in terms of can you stop degeneration, it's always easier to think about the spine when you think about the rest of the body. So your disc degenerating is much like the cartilage in your knees or the cartilage in your hips degenerating. At some point in time, it wears out to the point where you can't walk and you have enough arthritis where you elect to have a surgical procedure done. Now, what can you do to prevent knee arthritis or hip arthritis? The number one factor that causes degeneration is genetics. So unfortunately, we can't pick our parents. Or maybe fortunately, we can't pick our parents. But what we can do is certain things to live a healthy lifestyle. One of the modifiable factors is smoking. So if you smoke, that decreases the blood supply to the discs and to the cartilage, and that leads to earlier degeneration. So not smoking is critical, not just for your lungs and for cancer prevention, but also for degeneration. Additionally, if you are thinking about your disc as a shock absorber, the less load that shock absorber sees, the better it is for it in terms of longevity. If you have a car and you're packing it full of concrete, the shock's going to wear out quicker than if you just ride it normally. So weight loss is really critical as well. And any joint involves lubrication. Lubrication occurs with motion, so staying active. So whether it's cycling, swimming, running, whatever activities you do. So I think the combination of not smoking, staying fairly lean, and staying fairly active are your best chances of staving off degeneration. And once again, the critical part is, even though your spine may look degenerated on the MRI, that doesn't necessarily mean you'll have clinical symptoms from it. So I'm a spine patient myself, and my MRI, once again, looks fairly trash, but I'm an extremely active individual and don't have any complaints. I try to stay as lean as possible, and I don't smoke, and I stay active.
Excellent.
Yeah, and I absolutely agree with that. I mean, I think it's important when people feel like, well, I'm healthy, you know, I work out and do all this kind of stuff, you know, a fair number of patients that we see sort of here in the Midwest would be, you know, the farming population, for example. You know, and farmers are really strong. They're tough people, and they can, you know, they can lift a lot of weight and all that kind of stuff. But it's really focusing on core, and I think core strengthening is really key. So, you know, the spine. So, you know, as Dr. Patel mentioned, the discs are taking load, but there's muscles around the spine. So, and the stronger those you can get those muscles, ideally, you know, abdominals, lower back muscles. You know, ideally, the hope is that there's less force, you know, going through the actual spine, the discs and joints.
Thank you for those points. The next question is with regards to a compressed nerve. I was told I have a compressed nerve in my back. How do you treat a compressed nerve?
Well, I think the answer to that depends on what your symptoms are. So if you're having a compressed nerve and you're having pain shooting down your leg or your arm, then those are the symptoms that need to be treated. We always try to treat everyone non-operatively. Surgery is great. That's what we do for a living. We enjoy it. That being said, surgery has potential complications. So before we take the decision to operate on individuals fairly seriously. Before we go down that route, we want to maximize every non-operative option we have. So if we can have an MRI finding which correlates to your physical exam, meaning if you have a compressed nerve on the left side, squeezing your S1 nerve root, and you have pain shooting down the back of your leg to your bottom of your foot, and the MRI finding matches your physical exam, then we'd likely try an epidural injection or some form of non-operative care, maybe physical therapy as well. We'd give that a good trial for about 8 to 12 weeks and see how it goes. And if you're improving, fantastic, then you don't need surgery. I had a herniated disc. I'm a climber, and every time I would down climb, I would keep falling because my leg was weak from the herniated disc. And I took my own advice. I did physical therapy, and I took time and took some steroids, and I felt better and didn't need surgery. I was fortunate. Roughly 20% of people do need surgery, even if they try non-operative care. And if at 12 weeks you don't have the results that we expect, and you're still having pain and weakness and numbness, then surgery is certainly a good option. And surgery ranges from traditional open procedures to minimally invasive techniques where people go home the same day.
Great. The next question we have is, how do you treat arthritis of the back or neck surgically?
So, and I think that this all starts tying in, and you're going to start seeing a very similar theme here, you know, to sort of discuss what Dr. Patel just mentioned. The majority of patients that come to our clinic are not they're not getting surgery. So I think there's a little bit of a misconception. People get referred to a surgeon, and they're like, oh my God, I'm going to get a big fusion surgery, and it's going to be a long recovery, whatever it is. And I actually spend most of my day almost talking to some people out of surgery, based on their symptoms and their MRI findings and whatnot. And then we're always very conservative. So we start very conservative and then sort of work our way up. Now, in patients that have arthritis or degeneration that are coming in, whether it's involving the back or the neck, if their symptoms correlate with nerve compression, so that's really what we can treat well as surgeons, which is neurologic symptoms. So if they have symptoms of nerve compression, pain down their back or down their leg or down their arm, numbness, tingling, weakness, then we have various surgical means, and generally we try to avoid fusion unless it's required. Now, in some situations, patients do need fusion. So if patients with spinal deformities or instability of their spine, that can be caused by arthritis as well. Those patients would generally require a stabilization procedure as well. So we have non-fusion options where we do decompressions only, so things like laminectomies, foraminotomies, and then there's fusion options or stabilization options that would involve pedicle screws or stabilization, either going in from the front of the neck or the back of the neck and whatnot, and we do those in patients where that's required. So.
You know what? You mentioned a laminectomy. We have a viewer question, which I think perfect time to pop it in right now. When bone is removed during a laminectomy, how is that area kept strong post-surgery? Will the back be prone to more problems down the road?
Yeah, I think with just a laminectomy, it wouldn't. So from the surface, you have your skin, and then you have fat, and then muscle, and then you have your spinal canal. When we do a laminectomy, we're removing a very small amount of bone that covers your spinal canal, just enough to take away the pressure that we can see on the MRI, which is likely causing your symptoms. We're cautious not to remove an excess amount of bone, because if you remove too much, then you destabilize the spine. Much like if you're doing some construction in your house and you're knocking down walls, if you take out a support beam, now you have a problem. So we try to leave the support beams of the spine intact and remove the bone around it, which leaves you with a very stable spine. Post-operatively, it's even more important to maintain a strong core. We recommend people stay very active after surgery. And a lot of our laminectomy patients, at least my laminectomy patients, I see in my yoga classes. And yoga and Pilates and things of these natures are really good to keep your core very strong.
Thank you for that. The next question, what is cervical myelopathy? How do you surgically treat it?
So cervical myelopathy is generally also known as degenerative spondylotic myelopathy, is a condition that affects the cervical spine or the neck. It's caused by could be caused by various means, but the end result is narrowing of the canal where you have your spinal cord. Now, patients that present with spinal cord compression, it's a very different population than patients coming in with generally back or neck pain or even a radiculopathy, which is isolated nerve compression. When people have spinal cord compression, their symptoms could often be very somewhat benign. They could present with symptoms like balance difficulties, maybe some coordination problems. They might have some numbness in their hands. They might present with just noticing that, hey, I feel like I'm getting more clumsy with my hands, dropping things a lot more, problems with buttons, with their keys, with handwriting. So they could be very subtle findings, but if they start if those symptoms start worsening, those things could be common, obviously, in the general population as well, but if those specific things start worsening, then there's a concern that a patient may actually have compression of their spinal cord. And if the MRI findings show compression of the spinal cord, then that whole clinical picture together is what we call myelopathy, which is essentially a sick cord, so to say. Now, when patients have myelopathy, they'll also have generally some distinct examination findings when we examine them. Things like hyperreflexia, problems with balance or walking in tandem, or special spinal cord reflexes as well. And when patients start having those kinds of things, then generally we do talk to them about surgery, because damage to the spinal cord could often be irreversible.
Fantastic.
Yeah, often it's funny. Often people come into us with lower back pain complaints, leg pain complaints, and on these physical exam findings, we detect that they have some abnormal findings suggesting cervical myelopathy. When we probe a little bit further, they do have these balance difficulties and difficulties walking. And then we get a cervical spine MRI, and lo and behold, they have severe compression of their cervical cord. We tend to operate on that before we operate on the lumbar spine. So it's something that we're really aware of. Often we'll get referrals from our other colleagues who do total joint replacements or other types of surgeries. There's certain populations that are highly at risk of having cervical myelopathy. Rheumatoid arthritis patients are one of them, and we take care of a lot of rheumatoid arthritis patients over here. And it's important, if they're going to get any type of surgery where they're going to have general anesthesia and be intubated, have a tube put down their throat, that if they do have cervical myelopathy, that gets addressed before that procedure occurs.
Thank you. We're going to switch gears a little bit now. We're going to talk about surgery as a treatment option. The first question, there is a perception that back or neck surgery is not successful most of the time. Is that true?
Yeah, it's funny. We hear that all the time. And it's usually because people have an experience of an uncle who did poorly. But if that was the case, then neither Ilyas and I would have jobs, we'd be unemployed. So anything that doesn't work most of the time is not something that anyone would be doing. I would say, depending on the surgical procedure that you pick, most of the surgeries that we do have about an 85% success rate. So it's not 100% for sure, and this is why we try to maximize everything non-operative. But whether you're talking about surgery to take the pressure off the nerve or the spinal cord, or a big deformity surgery for fusion, there's roughly an 80-85% success rate with most of the surgical procedures that we do.
What has changed that makes surgery safer now or provides better outcomes?
Yeah, in terms of safety, a ton. I've been doing this for quite a while now, well over a decade, and the amount of technological advancements that have happened in the last 10 years are tremendous. One of the things that we do is we instrument the spine. So we put in pedicle screws, and these screws go in the bone past the spinal cord. We used to do it by feel, almost blind before. And even though we were pretty good at it, complications did occur. And now we use navigation, which essentially is kind of like using navigation in your car. It's a road map, and it shows us exactly where the trajectory of the screw is going to make it a lot safer. We're fortunate at Michigan to be involved in the development of a robot for spine use. And looking forward 5-10 years from now, I think that the robot in conjunction with navigation will make it even safer. Other things that are important are not spine surgical things, but preoperative things that we do now. I put more of an emphasis on that we never did before. So you want to essentially set your patient up for success. And the things that we could do preoperatively is to make sure that their bone quality is good. So osteoporosis is a rampant problem, but we're really aggressive about treating people and getting their bone as strong as possible before surgery. Nutritionally, people may think that they're healthy, but we run certain nutritional parameters, and we make sure that they are healthy enough to not only have surgery, but recover from surgery. And also in terms of pain management, we have a lot of patients that have been on pain medications for a very long time before surgery. If you operate on that person, they're going to have a very hard time afterwards weaning off those pain meds. So we work really closely with our pain management teams at Michigan to help people through that whole process before surgery to wean down, and also after surgery to eventually get off of pain medications. So I think these non-operative things also have been really useful in increasing our success rates.
Yeah, I think that's a great question, Ed, and along with what Dr. Patel said, basically, there's been a lot of focus in the literature and with research and whatnot on really optimizing patient outcomes. and figuring out which patients do well and what allows them to do well. And as was mentioned, a lot of it starts first of all with indications, having the appropriate patient selected for the appropriate operation, deciding on the right surgery, and then really optimizing patients before surgery. And we find so much of so many issues with spine surgery often occur because patients, for example, are still smoking. They're still significantly overweight or obese. Their bone density has never been looked at, so they have osteoporosis and whatnot. And so, although sometimes technically the surgery was great, often there's patient factors that really could be optimized to get a better result. So we're really trying to, as Dr. Patel mentioned, we're really trying to set the patient up for success. And although there's a number of surgical factors, there's also patient factors. And so really having that discussion with the patient that, look, like I really want, you to have a good outcome. And I want, your symptoms, your pain to improve. I want you to get back to work. And it's going to really take a lot of work on both sides, really, so.
Yeah, and other things that we do are less invasive procedures now. I remember when I first started training, for a laminectomy, we'd have a huge incision. And it's not so much a cosmetic aspect of a big skin incision, but it's all a soft tissue dissection below, which led to a lot of back pain afterwards, increased hospital stay, increased blood loss, pain medication use. Now we're focusing on minimally invasive surgery, and that same procedure, which we normally do through a 8-inch incision, we're doing now through a 22 millimeter incision. So less soft tissue violation leads to better outcomes in a lot of patients.
Thank you for that. Next question, what about traditional back or neck surgery? Is it as safe as newer surgical options for patients?
Well, I think that when we say sort of traditional, I think that that may need to be defined a little bit better. I mean, ultimately, the goals of surgery, the goals of spine surgery, have always been the same, which is basically to take the pressure off the nerves or the spinal cord, which is essentially a decompression, and if required, to stabilize the elements involved, meaning the vertebral levels involved. If there's a deformity, then we seek to correct that deformity. And so by traditional, it means, those kinds of things. Well, we still have the same goals. But the means in which we are obtaining those goals, with safer placement of pedicle screws, with minimally invasive approaches, using tubes or endoscopes in surgery, and even the way we put our pedicle screws in, we can often put those in with a minimally invasive approach as well. Being able to monitor the nerves while we're doing the surgery, so we can detect if there's any situation in which a nerve is potentially compromised. We can detect that right in surgery and do a correction maneuver if required. So these are all sort of the newer techniques, but ultimately the goals are still the same.
Yeah, and I think surgery is definitely safer than it was. It's funny, when we go in the morning and we sign in patients for surgery in the patient waiting area, it's just another day for us. I mean, this is what we do for a living. We do it all the time. But we understand from a patient's perspective, they're really anxious and nervous about it. I was kind of on the other end of things not too long ago when my dad had heart surgery. And I saw the surgeon walk in with his cup of coffee, and he was very casual about it because to him, he realizes that this is a relatively routine thing, a cardiac bypass procedure now. And the vast majority of patients do really well. Although from the patient's perspective, my dad's having heart surgery, and that's all I'm thinking about. But yeah, trust us. From the surgeon's perspective, surgery is certainly way safer than it used to be because of perioperative things as well as intraoperative techniques that we use.
Okay. Next question that we have is with regards to motion preservation surgery. Is it different than other surgeries?
Yeah, so one of the big things about spine fusions is when you take away motion at one segment, it puts more stress on the adjacent levels, or at least that's one of the theories. And that leads to breakdown at that next level, and then you need another spine surgery in 5 years. There are various things you could do to help minimize the risk of that occurring. Some of them, even with fusions, are technique dependent. So if we change our techniques, we can certainly help diminish the rate of that. But you can also do disc replacements. So instead of fusing across a disc, if you preserve motion across a disc, it puts less stress on the adjacent levels, and that would theoretically decrease the rate of you needing more surgeries in the future. Now, not everyone's a candidate for disc replacements, and they're certainly way more common in the neck than they are in the lower spine. But it certainly is something that we do, something that's well accepted nationally in the literature, and it has really good outcomes.
Okay, so now we're going to move on to a few more of our viewer questions. I have had 2 L3, L4, L4, S1 fusions in 2016 and 2017. I'm still experiencing a lot of pain and sometimes get a feeling like I'm bleeding, but MRI and CT show everything is good. And now I'm also feeling left side neck pain as well. Is the feeling of bleeding a normal side effect?
Yeah, so we fortunately have the opportunity to take care of a lot of patients who have had surgeries from the outside. And it's always a challenging situation, right? Because you've had this surgery and you come in with these CT scans, X-rays, and MRIs, and you still have discomfort. That's why you're coming in to see us. Now, we need to determine whether there's something wrong with that instrumentation or whether there's something else that's now compressed that's causing your symptoms. Or, quite honestly, were the indications not appropriate from the beginning? So if I saw you before you had any surgeries whatsoever and you had your pain, would I have offered you surgery? Now, sometimes patients have CT scans and MRIs and everything that look great when they come in and see us and they're still symptomatic. Likely that initial surgery, no matter how well it went, wouldn't have benefited them in the first place. So if you fall into that category, there's really not much that we can do. However, usually there's something that we can find on the imaging studies would suggest that some type of intervention would be beneficial. Things that we look for when people have had previous instrumentation is malpositioned hardware. Subtle findings like loose hardware can cause significant symptoms. And once again, they can be very subtle. Even radiologists can miss it on a read. And further nerve compression can also cause symptoms. In terms of bleeding, I've heard that descriptive term used before, and usually when people describe bleeding, it's usually related to some form of nerve compression still. So yeah, I've taken care of people with similar symptoms who have done well from revision surgery.
And I think it's important sometimes to look at, to sort of holistically look at the problem or a patient and what they're coming in with. If they're also describing some neck pain or neck discomfort, I think it is important to look more into that as well. Like I said, we said initially a detailed history regarding what exactly is going on, what the symptoms are, is there any radiating pain down the arm, or even if there isn't, just very subtle things, issues with balance, with falls, with clumsiness. So the problem could even be somewhere totally different that's never been looked at. And we do see that as well, where people have had numerous surgeries, for example, in their lower back, and then the problem is actually in their neck or up higher in the thoracic spine.
And even outside the spine. Often people will come in and they'll have numerous spine surgeries and they're still having difficulty standing up, and they have hip arthritis and they need a total hip replacement. Similarly, we see people that have had many hip surgeries and the problem is in their spine. So this goes back to the initial concept of making an accurate diagnosis before jumping into surgery. Now, there's a certain subset of patients who come into us to see us who have had plenty of surgeries, and they want a surgical fix for their persistent pain. Now, although we empathize with these patients and we really do want to help them, if there's nothing we can do, we're really honest about that as well. Exploratory surgeries or surgeries that you approach with the attitude, we'll give it a try and see what happens, those are almost never successful. Usually a physician's motivation to do that is to help a patient, which is what you want to do. You see someone in pain and they come to you and they say, you're my last option, and you really want to do your best to do good by them. And I've learned in my career that good intentions don't always lead to good outcomes. So right now, unless there's a obvious objective finding on an imaging study and we're convinced that we can help you out surgically, we'd rather have that tough conversation of nothing we're going to do is going to make you feel better. That's not discounting the fact that you have pain, but sometimes we just don't have the surgical solution to make you better. And I tell some people that I can definitely make you worse, and that's the last thing that we want to do.
The next question we have, this touches on something that you mentioned earlier, Dr. Patel, avoiding smoking as a contributor to disc health. So often patients consume cannabis by lungs. Does this type of smoking also impact the health of blood flow and recovery in bones and tissues? And then the follow-up question to that, what about patients who do not smoke but are habituated to things like nicotine gum?
Yeah. So the nicotine is actually the thing that leads to decreased fusions and affects blood flow significantly. Initially, when I made this big push to tell people to stop smoking, I would tell them to stop smoking and come back, and we'd have them do a urine test to make sure there's no nicotine in their system. And it was my fault. It was pretty poor communication. I didn't let them know that the nicotine was the important part. So they would chew Nicorette gum and they would stop smoking, which is fantastic for your lungs and a big feat in and of itself, but it really doesn't benefit your spine. So now we're pretty, have this open conversation about the nicotine being the negative in all this. And we ask people to refrain from any nicotine. We don't really know how long you should stop smoking for prior to surgery in order to optimize your results. We use 3 months as a general guideline. So if you stop smoking for 3 months and if you continue stop smoking for 3 months after surgery, we think that that puts you in a good enough group in order to lead to good outcomes. In terms of cannabis, it's really interesting. You know, this is something that we're dealing with more and more now with the legalization of it. For years, patients have been using it for pain management, especially cancer patients have been using it for a very long time. And we don't have, I don't think, enough long-term data to tell you the effect of cannabis in terms of fusion rates. I would tell you that it's an effective pain management strategy. And if that's what you're on before surgery, and if that's the only thing that you can be on before surgery, it's not like nicotine where it's an absolute no-go for surgery. But we'd really try to encourage you to work with our pain management doctors to really minimize how much cannabis you're smoking and to minimize any narcotics you're taking preoperatively in order to obtain the best outcome after surgery.
The next question that we have, next viewer question, what are the benefits cited most by your patients post-surgery? Why is it worth it?
So I think, I think there's a number of benefits. I think it's important to realize that the patients that we're operating, generally they have a tremendous amount of pain. So they're in debilitating pain that's affecting their quality of life. You know, they often they can't work, or if they're not working, they just can't enjoy life. They can't stand up and walk in a grocery store. They can't go to the park with their kids or pick up their grandchildren or whatever it is. You know, and so they're in a tremendous amount of pain. And I think that the biggest benefit and the goals that we often tell patients is we're doing this operation generally to help with pain, primarily, you know, leg dominant symptoms or arm dominant symptoms, or if there's deformity or instability, then back pain as well. And so the biggest thing that I see in patients, at least acutely, meaning right after surgery, and often it's not uncommon for patients right in the recovery room to be like, hey, that pain that I had down my leg for years and years is gone. You know, I just don't even feel it anymore. And that's one of the greatest sort of job satisfaction aspects of it for me, that when patients tell us that, it's just so rewarding because this nerve pain is just extremely debilitating. So that's acutely, and then patients often have improvement in their pain. But then they, with myelopathy patients, as we had discussed, often over the course of, and sometimes it could take time. So that's not every patient that has immediate improvement, but sometimes that could take time over the next several days to weeks to months. Sometimes up to a year or even 2 years with spinal cord recovery or improvement. And sometimes it's not complete, but that recovery of neurologic symptoms, so improvement in walking, improvement in balance, and hey, I can just walk better, you know, and it's easier for me to do the things that I want to do. So seeing that in patients is extremely rewarding for us.
Yeah, I think for me, the operative thing is function. The most important thing is function. When people are in pain, sure, the pain is not fun, but what it limits them from doing is actually the thing that drives them into our office. Daily things we take for granted, like walking in the grocery store and doing your shopping, or going to dinner with friends or vacation. These little things are huge. I'm a very active individual. I like to run, bike, climb, and if I can't do these activities, I'm not a happy individual. So restoring people back to function is, I think, the biggest benefit of surgery. Whether it's an 80-year-old woman with a compression fracture that you help out and they can walk again and do their daily activities, or an active individual who's 30 years old who hasn't been able to run or bike or climb, who you can restore back to that functionality. I think that's what people are most grateful for. When you look at our testimonials of patients that we operate on, most of them will always comment about what they weren't able to do before and what they are able to do now.
Okay. The next viewer question, correct me if I mispronounce anything here. Thoracic three-quarter disc surgery. Can it be done or is it too risky?
I guess I don't understand the question exactly, what thoracic three-quarter disc surgery is. Now, if the reference is to a thoracic discectomy, so doing a disc herniation in the thoracic spine, it's a little bit different than taking care of a disc herniation in the lumbar spine, because the structure of the spinal cord in the thoracic spine is such where you can't retract or manipulate it. So you need to be more cautious. Traditionally, we would do those surgeries through big transthoracic approaches where we would take out a rib and go in through the chest. And now we can do them through smaller approaches from the back where we approach the disc herniation lateral to the spinal cord and work our way to the midline. So yeah, you could certainly do them. And patients actually do have really good outcomes for them. They don't occur that often, but when they do occur, they do have a really good surgical treatment.
Okay, the next question that we have, what is prehab care and does it improve outcomes for a patient?
Yeah, and just like we were talking about before, prehab is one of the biggest things. I actually just gave a talk on this about a month ago about the importance of prehab in patient outcomes and how we're modifying what we do to maximize this prehab. And for me, prehab has three big arms. And the things that we focus on are bone health is number one, nutrition is number two, and preoperative pain management is number three. If you can prehab patients and you can maximize their bone health, their nutritional health, and help with their pain medications, you can really make a massive impact in their overall outcomes after surgery.
Very good, very good. Dr. Aleem, anything to add?
No, and I think the only thing I would add to that is really is almost like rehab before surgery. I mean, weight loss and basically trying to do as much. I mean, physical therapy is often difficult for patients because they're in pain and they're limited by that, but as much as they can before surgery. So
we've talked about prehab. What can a patient expect in the days immediately after back or neck surgery?
Yeah, I think it's a broad question because the surgeries that we do are so different. So we do some procedures which take 15 minutes, like kyphoplasties where we put cement in broken vertebrae. SI joint fusions take maybe a half an hour. Discectomy for disc herniation takes maybe a half an hour. And these patients have a drastically different course of post-operative course than patients that have big deformity surgeries, whether it's the cervical spine or the thoracolumbar spine, which sometimes tend to span over 2 days. So if you are in the shorter surgical group, outpatient to 24-hour stay kind of group, our goal is to mobilize you as quickly as possible, get you as walking as fast as possible. That helps prevent complications like blood clots and pneumonias. And being active is what we are doing the surgery for. So those patients usually do really well, get out of the hospital really quickly, and really don't have too many postoperative restrictions. The restrictions that we put on is for a couple of weeks until the wounds heal, and then beyond that, they're really free to do what they want to do. We have patients traveling, going on vacation, running really quickly postoperatively. The other demographic is the bigger surgeries that take a day or 2 days to do sometimes for big complex deformity cases. Now, some of these patients end up in the ICU afterwards. It's always a planned thing, but that course is drastically different and they take up to a week in the hospital. Our key criteria before we discharge someone from the hospital is to make sure that their pain is very well controlled. And also to make sure that they're safe to go home. Last thing we want is to send someone home after a big procedure and then they fall and get hurt and have another problem, right? So we work really closely with the therapist to make sure that patients are cleared and safe to go home. They feel comfortable going home. Their pain is well managed. And very graphically, we're pleased with the work that we've done. Those patients usually, our target is to get them back to full function at 3 months. People have this false conception of bed rest being something that we prescribe. We never prescribe bed rest. even in some of these really massive procedures, we want patients up as quick as possible. So bed rest and inactivity is a thing of the past. We want you walking as much as possible during your rehab. And after 3 months, if you've had a big fusion procedure, then we start lifting any restrictions that you may have.
And I think that's an important point you brought up there. Often patients, what they ask us is, how long will I be out for? You know, and I always tell them that it really just depends on what you mean by out for. You know, if you're talking about being bedridden or just being bedbound, they can't get up and need total care, well, that's really only during the operation. You know, so there's some good data now suggesting that mobilizing patients on post-op day 0, which is the day of surgery, so meaning that you have surgery, you know, and then later that evening or that afternoon, getting patients up, even if they've had bigger operations, ideally with the right help, with physical therapy, with nursing staff, getting them up, and even if we can get them up to standing up in a chair and whatnot, that significantly improves patient outcomes, you know, and decreases, you know, things like urinary retention and days in the hospital and all those kinds of things. So, so walking is always good. We want patients up, we want them walking, and essentially moving.
Thank you for that point. Back to that question on the thoracic disc surgery. Update from our viewer, they meant levels 3 to 4 thoracic disc surgery.
Yeah, I mean, you could certainly, so thoracic surgery presents the same challenges, whether it's at T3, T4, or T7, T8. And the challenges are the structure of the spinal cord and the inability to retract the spinal cord. But the same techniques that we use in the lower thoracic spine we'd use in the upper thoracic spine in order to help take care of disc problems. There's a technique that we use, it's called a transpedicular discectomy, which means if this is the spinal cord, just going off to the side of it, not retracting it, and still gaining access to that disc. Yeah, so it's certainly a technique that we use to help take care of upper thoracic problems.
Okay. Our next question, I'm a post-liver transplant patient from 2015. I need surgery on my back because the leg pain is getting incredibly painful. Obviously, I'm on anti-rejection drugs. What do you think about my chances of fighting off an infection if I have the surgery?
Yeah, that's a great question. We're fortunate enough to work at a really big medical center which has an excellent transplant team. So we deal with patients who have had transplants all the time. I always tell patients I think that I'm the ideal surgical candidate. I'm 44, I'm healthy, I don't have any medical problems, my bone is good, and I don't take any pain medications. But unfortunately, people like me don't need surgery. So most of the people we deal with have some form of challenges, whether it's a liver transplant patient on anti-rejection medication, someone with rheumatoid arthritis on high-dose steroids. So we deal with these things all the time. So chances of infection are clearly higher in a subset like you, but we do different things intraoperatively and postoperatively to help diminish infections in someone like yourself. Routine intraoperative and postoperative antibiotics are pretty critical. Depending on the type of surgery that we do, we modify our closure and we put on something called superficial wound vacs to help diminish collection of blood underneath and help promote healing. Healing is really heavily determined by nutrition. So although you're on those anti-rejection medications, we can optimize your nutrition to help wound healing. And really important is when you do have a post-operative complication, like an infection, to address it and be aggressive about treating it, right? So surgery sometimes is 2 steps forward, 1 step back. And you can have a great outcome, but then something will happen where you have some wound dehiscence, some blood collection underneath, and you need to address that. I think some people have the attitude where they bury their head in the sand and hope it goes away. And I think we tend to be more aggressive about it. So if someone is at risk for an infection, we'll do all these things to help minimize the chances of them happening. But if they happen, then we're pretty aggressive about taking care of it. If you wash it out and take care of it with the appropriate antibiotics, we are able to get pretty much everyone through a postoperative complication. So.
Yeah, and again, thank you for that question. I mean, I think that's one of the things that, you know, as Dr. Patel mentioned, I think we're very fortunate to work at a big medical center like Michigan Medicine, where we have really 24-hour access to all of these medical specialists. And so all the way from preoperative referrals to the surgery itself, and then post-operatively, whether it's infectious disease doctors, transplant teams, medical doctors, the orthopedic, the surgical team. I mean, there's a tremendous access here, and by and far, we have many patients that have significant medical comorbidities that have done very well.
I think that viewer said something really important, which was the pain is getting so bad down my leg that I can't deal with it anymore. I mean, when you get to that point, then I think surgery is a good option, right? It's always weighing the risks and benefits. And sure, you're at a higher risk profile. So if you had an annoying pain, which really wasn't limiting you, it was more of a nuisance, then we would counsel you not to get any surgery done. But when it gets to the point where this leg pain is really limiting your function, and then it's worth taking the risk, even though you're at a higher risk profile, to help alleviate these symptoms so you can be functional again.
Thank you for that. Next viewer question, do you advocate for complementary medicine for things like pain, especially post-operation? For example, acupuncture in particular?
I think that, I really think that complementary medicine, especially in the sort of back pain or the neck pain population, whether it's chiropractic manipulation or acupuncture or, traditional Chinese medicine or any of these other methods, a lot of patients have, used these other alternative modalities, and for a lot of people it actually works. At least just anecdotally, they say that, hey, I went to a chiropractic, I got certain manipulation, whatever it is, and I felt better. I think that we don't have enough evidence in the scientific literature to show that a specific modality works. But certainly, what I tell patients is that if you've tried it and it works for you, then that's fine. So, and I think it is important to look at a patient holistically, and both of us advocate for that in the sense that we want to look at a patient holistically and look at the symptoms that they're having, the problem that they have, and sometimes there are limitations to what we can do surgically. And in those situations, patients that are willing to try other modalities, then it may or may not work. So I don't advocate for one or the other, just because the evidence behind it scientifically isn't very strong. That doesn't mean it doesn't work, So.
And also, I think we both believe in this mind-body connection. Now, we're not pain management doctors, so we're surgeons. We operate on people and we make them feel better. And we're fortunate enough to have colleagues who are pain management doctors. And pain is a very interesting topic. Pain without any anatomic cause is a very real thing. When patients complain of pain and their MRIs are normal, it's not that we're discounting the fact that they're in pain. They truly are in pain, otherwise they wouldn't waste their time out to come see us. And there certainly is this mind-body connection thing, and our pain colleagues are really good at working with people about it. Meditation is also a very useful tool post-operatively to help out as well. So I do believe in these alternative methods.
Thank you for that. Next viewer question, have you seen success with spinal cord surgery for multiple lumbar surgery pain, sciatica, bilateral radiculopathy and numbness?
Yeah, it's honestly probably our bread and butter and probably the most successful thing that we do. It's really rare when people get older that they have arthritis only at one lumbar segment. It's kind of like saying I have arthritis in only one part of my knee. It affects the whole knee, usually both knees and both hips and ankles and everywhere. So patients will often have multi-level lumbar arthritis, and it causes sciatica, difficulty walking, and that compromises, I think, the bulk of our practice. Those are the happiest patients. The patients that are really limited because of this lumbar nerve compression, and they get decompressions or decompression fusions and can actually live their life again are the most successful patients that we have.
Yeah, and again, thank you for that question. It's really, especially with our practice and our referral base here, we see often a complex spine. Both of us have a complex spine practice. We see generally more complex spine cases. And so by and far, the majority of the patients that come to us have multi-level disease.
I think you've done such a great job of fielding all these questions. The next one that's come in, do you both participate in any spine surgery research projects?
Yeah, we're both actively involved in multiple spine societies. Cervical Spine Research Society, Ilyas is very involved in it. He's actually doing a traveling fellowship, which he can tell you about, which is really a great thing. Lumbar Spine Research Society, we're involved in several projects at the University of Michigan and some multi-center studies as well. These studies are clinical, some of them are animal-based. So yeah, we're involved in a bunch of research, but I'm really proud of Ilyas for getting this cervical spine traveling fellowship. It's a real honor that only a couple of people get, and I think you should tell them about it.
Yeah, no, thank you very much. So, I mean, I've been very fortunate with the practice here. So I have primarily a cervical spine practice. I would say about 60-70%, and it's a patient population I really enjoy working with. And I've had the opportunity to be involved with numerous studies looking at this population. And I will be leaving in a couple of weeks to do this traveling fellowship, visiting India, China, Korea, South Korea, Japan, learning more techniques and sort of diversifying my toolkit, building international connections with regards to treatment of cervical spine patients. So both of us are motivated by improving outcomes in spine surgery patients, and that's what drives our research.
We also have a great opportunity to work with companies that are developing new technology. Some of these companies approach the university directly, and they have an office which will link us to companies that have new ideas. Some of it is through industry, but working with industry and these companies has given us a good opportunity to come up with new surgical techniques and new products like robotics, and to be innovators in this field to help progress spine care, to make it healthier, safer, and easier for patients.
Great. So we have a little bit of an update from one of our previous questions where we were talking about spinal cord surgery. The viewer actually was referring to spinal cord stimulators.
Yeah, so another area where I personally do spinal cord stimulators, but we certainly refer plenty of people for them, and we definitely believe in the benefit of them. So our role for spinal cord stimulators are in patients that have nerve-related pain, but don't have any documented source of compression for us to alleviate on MRIs or CT scans. We work really closely with our non-operative pain providers, who are PM&R doctors and anesthesiologists, who are excellent, and we'll refer patients over to them who we feel would be good candidates for a spinal cord stimulator. They would get assessed and worked up, and if those doctors feel like they're good candidates, then they would get a spinal cord stimulator trial done. And if it gives them good results, then they would have a spinal cord stimulator implanted. And we've certainly seen good outcomes with this in the correct demographic.
Great. The next viewer question we have: can sleeping with your arm above your head and laying on it cause permanent neck damage? Should I find a different position to sleep in? That could be from me, basically.
Yeah. Go ahead.
I would say no. You should sleep in a position that you find comfortable. A lot of people generally they would ask us about mattresses, a better firm mattress, soft mattress, or certain sleeping positions and all that kind of stuff. So I haven't come across any scientific literature showing one is better than the other. So for the most part, what I tell patients is do what's comfortable for you.
This mattress question is really funny, and so is the pillow question. And these price ranges are so silly for mattresses, $5,000–$6,000 for a mattress. And I always tell people just go to a store and try on what fits best for them. And if you want to know what a spine surgeon sleeps on, a bed-in-a-box mattress, which literally the mattress came in a box and it was $600. So yeah, there's no science that says that one mattress or pillow is better than the other.
Thank you. That's great information for our viewers. Now we have approximately 2 minutes left. So before we end our session, a couple of quick takeaways. I'm going to ask each of you to tell our viewers the one thing you feel is most important for them to know about spine surgery. Dr. Aleem?
Yeah, so I would say that, as I mentioned earlier, when people come in with spinal problems, often it's very debilitating. I think when patients come in to see us, they think that we're going to recommend a massive operation for them, and both of us are very, very conservative. So I think by and far, in the vast majority of patients that have neck or back pain, surgery we don't recommend surgery for. We recommend a conservative approach: physical therapy, activity modification, symptomatic pain pain control, maybe an injection. But for the patients that essentially need surgery, have exhausted those other options, and have significant dramatic decrease in their quality of life, we have the toolkit now to safely perform surgery to improve outcomes.
Okay. Dr. Patel?
Yeah, surgery's come a long way. I mean, look at the phones that you had 20 years ago, look at the TVs that you had in your house 20 years ago, and look at the cars that you used to drive, and compare them to where you are now. Huge advancements. And if you can imagine the amount of money that's been poured into advancing the field of medicine, huge advancements have been made in spine surgery. So it is a safe surgical option should you need it. And the vast majority of patients, over 85% of patients, are really happy with the results they get. So it is something that is not only safe, but it's often very successful.
Fantastic. Thank you both for your expertise. Thank you for coming here today to be on this Facebook
Thank you for your
Live.
time.
Now, to our viewers, if you're interested in sharing a recording of today's chat, it's going to be up on the Facebook page, and we will also be putting up on our Michigan Medicine YouTube channel shortly thereafter. So thank you both for joining us. Thank you to our viewers as well, and have a wonderful afternoon.
Thank you.
Thank you.